please. Yes. If you want, this is the problem. Sure. So. Should we start?
Yeah.
Good morning and welcome to this session of three papers liver. This is Professor Gamblin from the Medical College of Wisconsin, and I am Professor Esposito from Milan, and we are going to share this session. We have 10 minutes for each presentation, so obviously please stay on time. And I think that we can start with the first presentation, Claire Goumard, Early Rehabilitation Following Laparoscopic Liver Resection, a Nationwide Analysis. Please. Hi, Doctor.
Hi, good morning, ladies and gentlemen, dear moderators. Thank you for allowing me to present this nationwide study analyzing prognosis factors for early rehabilitation following laparoscopic liver resection. I use this to move, right? Okay.
Yeah.
I do not have any financial interest statement. And as an introduction, you all know that now laparoscopic liver resection has repeatedly been reported to be associated with patients' postoperative rehabilitation, improved rehabilitation. And now we have many retrospective studies and many reviews showing the advantages of laparoscopic liver resection. For HCC, for example, in this review on the left side, analyzing more than 3,000 cases. And we also have a randomized controlled trial for colorectal liver metastasis showing the advantages of laparoscopic liver resection in terms of postoperative complications or hospital stay or even quality of life. And so these advantages have led to the need of stratification of difficulty in laparoscopic liver surgery. Why? Because there's an extension of indications because of a rising consensus and evidence level of laparoscopic approach, and also we need for standardized learning and difficulty stratification. And there's several scores and classifications to stratify difficulty in laparoscopic liver resection. One of the simplest of them, the one we use actually in clinical practice, is the EMM difficulty score, which grades laparoscopic liver resection in three grades: low grades, wedge resection, small wedge resections, and left lateral sectionectomy. Grade 2, intermediate, it's anterolateral segmentectomies and left hepatectomies. And grade 3, high difficulty, is segmentectomy in posterior superior sections or any other major hepatectomy. So this classification has been correlated to morbid mortality and has been built based on three main parameters: operative time, blood loss, and conversion. And according to this, the objective of our nationwide study was to create a model integrating this difficulty classification, the EMM1, to anticipate the patient's probability of experiencing early rehabilitation following laparoscopic liver resection. And I will, of course, define what early rehabilitation is for us. So this is a national survey, including 27 French centers. And so we gathered data from more than 4,000 laparoscopic liver resections on 17 years. And we studied factors associated with length of stay in one hand and 90-day readmissions in the other hand, using multi-level regressions to disentangle the in-between centers effects. And so early rehabilitation was defined as patients having no prolonged hospital stay, defined as less than 7 days because of the 7/5 percentile of the median of length of stay in our cohort, and no readmission. And based on that, we built a predictive model based on that selection procedure, which was done with a random forest selection. So we gathered data from 3,220 patients who underwent laparoscopic liver resections either for malignant lesions, HCC metastasis, or benign lesions. And in these patients, we had 1,615 grade 1, 700 and more grade 2, and more than 800 grade 3 procedures. The mean age was 46 years old. There was approximate 60% of malignant lesions and 35% of HCC, and about 30% of underlying fibrosis, F3 or F4. There were approximately 30% of major hepatectomies, of course, depending on the grade. Pedicle clumping occurred in about 20% of the cohorts, conversion about in 10%, and we had an overall complication rate of 38%, with 7% of severe complications and a mortality of 1% in the whole cohort. And so we studied specifically the factors associated with, in one hand, length of stay, and in the other hand, readmission. So factors associated with length of stay were age, the difficulty grade, EMM grade, major resection, the number of lesions, and the indication. The indication was divided in 3 categories: primary cancer, metastasis, or benign. And factor associated with readmission was major resection and indication. And so based on that, we built a model, a final model, selecting 5 variables with the method of random forest. And those 5 variables associated with early rehabilitation were age, EMM difficulty grade, major resection, indication, and fibrosis grade. Early rehabilitation accounted for 1,762 patients, 64%. This final model was tested in terms of precision, ROC curve, with the area under the curve of 0.73, and precision recall, and the precision was graded on 0.8, which is quite a good calibration and precision. And based on that, we built a nomogram. I'm sorry, we don't see very good, but the nomogram was based on these 5 variables selected previously. And so, as a conclusion, we built a simple model, including the EMM difficulty classification, which allows to have a reliable preoperative identification for ideal candidates for early rehabilitation following laparoscopic liver resection. Thank you for your attention. I would like to thank all the centers involved in this study.
I love the fact everyone's set up close. No one's on the back row. So congratulations to the crowd for showing up and being up close and a personal. Very nicely presented, excellent job, and what an esteemed group you come from. Any questions from the audience? I might just ask you, in France it may be quite different in the US, but are the patients admitted the day before surgery? Yeah. Your length of stay reflects patients are actually admitted the day prior to their operation? It depends on the hospitals, but usually the day prior surgery, but it's not including in the length of stay. I see. It begins in the day of surgery. Excellent. Did you consider just excluding the patients that were converted to open? It seems they may lengthen your length of stay and such in the 3 grades, and you know, if they're done open, then we would anticipate, obviously, that, you know, one thought would be to say, if completed laparoscopically, what would be the rehabilitation? Right, that would be interesting. It's just we were not in intention to treat fashion anymore, but yeah, that would be interesting. Very nice. Yes, sir. Yeah. The 3 difficulties. What was the length of stay? Because you defined length of stay 7 days and more. Yeah. As not early rehabilitation. What was the median in patients less than 7 days? Specifically in this group, because the median overall was 6 days, and in grade 3 it was 7 days, 5 to 10. Because we can achieve, you know, or we do in Cardiff, the median stay for open liver resection is 6 days.
Yeah.
And the aim is to go to 5 days. We do have a significant number of patients going home in 5 days. This is not predicted discharge, actual discharge home. And do you think what is holding these patients after laparoscopic resections for 6 days?
I'm sorry, I didn't get the question.
Sorry, the question is that the advantage of laparoscopic surgery is early rehabilitation, early discharge home.
Yeah, sure.
But you're saying that the median stay for major resections
Yeah.
is still 6 days.
Yeah.
Many units achieve 6 days in open liver resection, not laparoscopic,
Yeah,
not open,
okay.
but actually open. So what is making these people stay for 6 days even after a laparoscopic procedure? So what
Yeah,
I'm trying to get at is what is making them stay is the major procedure rather than the approach.
Yeah, I agree with you, but actually we just thought statistically and took the 75th percentile of the median. But I agree with you, we can say that, but I still think 7 days is a nice cutoff to see which patients go well and which patients really don't after a resection.
Thank you so much. Very nicely presented.
Thank you.
Our next paper is entitled Bile Leak After Laparoscopic and Open Liver Resection Incidence and Clinical Impact, an international multi-center propensity score match study of 13,379 patients. This will be presented by Burek Gorjek from the Netherlands. Welcome.
Yes.
Thank you for being with us this morning.
Yes, thank you very much for the introduction and being here for the presentation. Let me see if this... Can we have the presentation here?
If you could pull up the next talk, please. This in-person meeting is, something new for us now that we're so virtual, right? So having you here and pulling up your talk is a nice, pleasant change in the speed of things.
We have time, so we can wait.
That's right.
Yes, great. So thank you very much. Good morning all. I would like to tell you something about our study, bile leakage after laparoscopic and open liver resection, the incidence and clinical impact. First of all, I have nothing to disclose. Some background information. Recent refinements in surgical technique have expanded the use of laparoscopic liver surgery. In fact, laparoscopic liver surgery has gained more acceptance as a feasible and safe procedure, not only for minor liver resections, but also for major and complex resections. However, laparoscopic liver surgery remains challenging with relevant rates of postoperative morbidity and mortality. So one of the most common postoperative complications following liver surgery is postoperative bile leakage. And it is suggested that bile leakage is a strong prognostic for poor postoperative outcomes following liver surgery, associated with delayed drain removal, a prolonged length of hospital stay, but also the need for additional re-interventions and diagnostics. However, previous studies in this field on bile leakage have mainly focused on patients undergoing open liver surgery, and studies focusing on laparoscopic liver surgery in this field are scarce. So therefore, the aim of our study was to compare the incidence and clinical impact of bile leakage between patients undergoing laparoscopic and open liver surgery in a large international multicenter cohort using a propensity score matched analysis. To do this, we performed a retrospective cohort study, including data from 15 liver surgical centers, all with extensive experience in laparoscopic and open liver surgery. And we included adult patients who underwent a laparoscopic or open liver section for all indications without any bilioenteric anastomosis between January 2000 and October 2019. So outcomes focused on in this study were the incidence of clinically relevant bile leak, defined as grade B/C bile leak according to the ISGLS definition. And we also focused on the clinical impact of clinically relevant bile leak with regards to postoperative outcomes. So for the clinical impact of postoperative bile leakage, we did two different analyses. The first one was to compare the postoperative outcomes of patients with clinically relevant bile leak after laparoscopic liver surgery and open liver surgery. And the second analysis we did was comparing patients with and without clinically relevant bile leak in the laparoscopic group and separately also in the open group, and subsequently comparing those two results with each other. So after all, a total of more than 13,000 patients were included in the analysis, more than 6,000 patients in the laparoscopic group, more than 7,000 patients in the open group, and after propensity score matching, more than 3,500 patients in each group remained for the main analysis. So this table shows the baseline variables after propensity score matching of the patients in the laparoscopic and in the open group. And what we see is that after propensity score matching, there was a fair distribution of the variables between both groups. Especially the extent of resection in both groups was comparable. So this table shows the incidence rates of postoperative bile leakage overall and grade B and C separately. And what we see is that before and after propensity score matching, the incidence of clinically relevant bile leak in the laparoscopic group was lower than in the open group, significantly. 6.4% versus 2.6% in the laparoscopic group. So this table shows the postoperative outcomes of patients with clinically relevant bile leak in the laparoscopic group and in the open group. And what we see is that patients in the laparoscopic group with clinically relevant bile leak had less severe additional postoperative complications, had a shorter length of hospital stay as compared to patients who had a open liver section. And also important to note was that the 90-day in-hospital mortality was lower in the laparoscopic group as compared to the open group. So this table shows the analysis comparing patients with and without clinically relevant bile leak in the two approaches separately. And what we see is that in the laparoscopic group, less variables are significantly different between patients with and without clinically relevant bile leak as compared to patients in the open group with and without clinically relevant bile leak. In the laparoscopic group, only the length of hospital stay was significantly longer in patients with clinically relevant bile leak, and also the readmission rate was significantly higher. So in conclusion, laparoscopic liver surgery seems to have a lower incidence rate of clinically relevant bile leak as compared to the open approach. Our findings suggest that clinically relevant bile leak negatively affects outcomes after both laparoscopic and open liver surgery, but it is important to note that patients after laparoscopic liver surgery with clinically relevant bile leak have a less impactful experience of postoperative outcomes as compared to patients who underwent an open liver section with clinically relevant bile leak. And at last, I would like to announce that our paper has been recently published in the Journal of American College of Surgeons. Thank you very much for your attention.
Thank you for this very nice presentation and very interesting study. Are there any questions? Yes, please.
Hi, thank you. Osmund Fretland from Oslo, Norway. Great presentation. I wanted to ask you if you think that there is factors here that the propensity scoring might not actually catch. Because I'm a laparoscopic liver surgeon, but I don't really see why there should be a difference in bile leak in laparoscopic and open. Or if you think the matching is perfect, then I would like to ask, why do you think laparoscopy is better?
Yeah, so the matching was almost perfect. So there was I think one variable, the size of the lesion, was significantly higher in the open group as compared to the laparoscopic group. So that could be a variable affecting this difference. And we know in the literature that that could be a factor for different outcomes, including bile leakage. But I also believe that laparoscopy has something that prevents any bile leakage and creates also less impact. For example, the parenchymal transection we do with the CUSA could be something with less impact on the tissue, and also probably the feel we have with the laparoscopy on the small vessels, on the bile ducts, could be something that could prevent any bile leakage in the laparoscopic approach as compared to the open. So that's a possible explanation for it.
Sure. Along the same lines, so the technique of dividing the parenchyma at these institutions is the same laparoscopically and open?
Almost the same, yes. There are some differences, but regarding the parenchymal transection, it is almost the same. Most of them use the CUSA, I think, yes.
And you know, it's always a source of controversy at this meeting. It always will be, I guess. But everyone received a drain. No one received a drain. The diagnosis of bile leak was made with the drain in place, or were drains placed? Was it propensity match for the patients that had drains and didn't have drains?
That's an important question. Data regarding drain placement was not available, so we couldn't match for that factor. But I think that's an important element which could influence the difference in incidence rates of bile leak between both groups. Yes, you're right.
And what about bile leak healing? Because I would expect that healing after laparoscopy is a bit longer because of less adhesions and so on. And I was wondering if you have data about this.
Not so specifically. The data we have is retrospective, so this was not collected. But I think it is important in future studies to look at this factor, what the effect of healing is for bile leakage and the incidence of it, yes.
Congratulations, very nice presentation.
Thank you. Okay, the next presentation from Dimitri Raptis, outcomes of liver surgery worldwide. We have it here.
Thank you very much. Indeed, it's a great pleasure to be able to present at the HPBA in person, not through a screen from home. It's an amazing feeling. And it's also a great pleasure to be able to present the first results of livergroup.org at the HPBA. So what is livergroup.org? It was a snapshot study on liver surgery worldwide over 3 months that took place in 2019. And the primary aim was to provide a verified record of the true morbidity and mortality after liver surgery. It's been reported anything between 0 and 6 in large epidemiological studies. And most important, to identify potentially modifiable predictive factors of outcomes after liver surgery. So this study was initiated by Dr. Eric Schade and led by Alejandro Serrablo, Massimo Malago, and myself. We also had a quite strong scientific committee that overlooked the study. Participation was from 136 institutions worldwide, 36 countries. You may notice that Canada and Australia are missing. However, we did receive data from centers that normally do not report the data, from low-income country centers, from private hospitals, and their data have never been analyzed or shown. After cleaning the data, ensuring no completion of data, we ended up with over 2,000 cases to analyze, and these were prospectively collected. Majority of the cases were operated for colorectal liver metastases, followed by HCC, non-colorectal liver metastases, intrahepatic cholangiocarcinomas, and perihilar cholangiocarcinomas. 14% of the patients had the previous liver resection. Normal parenchyma prior to surgery was only in nearly slightly more than 1/3 of the cases. Only 4% in this cohort received a portal vein embolization, and everybody played safe with a median SFLR of 42%. 73% of all cases were done openly, 22 laparoscopic, 2 were robotic, and 2 had to be converted to open for minimally invasive surgery. Operation duration was 4 hours. Majority of the operations were, in fact, wedges, followed by right hepatectomies, segmentectomies, left hepatectomies, left lateral and right posterior sectionectomies, bisegmentectomies other than left lateral, right posterior, extended right, extended left, and trisegmentectomies excluding lefts. Ablation and resection was only in 5% of the cases. Pringle was used in 44% of the cases, and the Pringle time was 25 minutes, nearly half an hour. In order to be able to compare outcomes among different groups, we created the complexity of liver surgery score in order to make sure that we're comparing the same populations. This we gave a single score for hilar lymphadenectomy, more than 1 liver resections, resection and ablation, venous, biliary, enteric resection and reconstruction, or non-GI resections. And the complexity score, the overall mean complexity score, was 0.6. And we then multiplied all scores by 10 in order to be able to better compare it with morbidity and mortality that are usually 2 digits. So the transection technique, majority used the CUSA, followed a third used additionally bipolar, 14% a stapler, which was mostly in the laparoscopic group, and 14% used the crash clamp technique. Transection time was 60 minutes, blood transfusion were not required, and on-table extubation was 80%, which is quite high. Now, looking at outcomes and complications used in Cleveland-Didot score until hospital discharge, the overall complication rate was 42%, major complication rate, anything from grade 3A and above, was 16%, and in-hospital mortality was 2.1%. You will see that at 90 days, mortality doubles. What were the most common types of complications? Infections, bile leaks, bleeding, ascites, and organ failure. ICU stay was 1 day, hospital stay median 8 days. This is an important slide. I would like to focus on the first set of columns. So blue represents complexity of liver surgery, and 20 means two parameters present. Gray represents major morbidity rate, and red represents mortality rates. Perihilar cholangiocarcinomas, mortality rate was 19%. It's double of what is known in the literature, double from what is published from systematic reviews. And it's also a nice example to those who would like to criticize snapshot studies that people selectively report. Cannot imagine people selectively reporting only deaths. Intrahepatic cholangiocarcinomas had a mortality rate of 5%, gallbladder cancer 10%, 11%, which is quite high. And then colorectal liver metastasis, for example, only 2% at 90 days. And HCC doubles, obviously, because of the liver parenchyma being diseased. And as you see, 90-day mortality overall is 3.8% worldwide. But we did see a huge difference from ranging from 0 to 9% in mortality in high volume centers. And we defined those that operated on 30 cases within 3 months, which is over 100 per year. So here are the top centers that have performed more than 30 cases. It ranged from 0 to 9.4. So still do not understand why the mortality is so huge. When it comes to the the approach, the surgical approach, open surgery was associated with 4% mortality. Lab converted to open, we had a nice presentation about laparoscopic liver surgery, was slightly higher, obviously representing difficulties intraoperatively. Laparoscopic is also it's not without mortality, 2%, and robotic, highly selective, low complex cases had 0 mortality. And the most risky operations were left transectionectomies with 11% mortality, followed by right transectionectomies and so on. And as you can see, the four columns, the first four columns, if a patient required venous, arterial, biliary resection and reconstruction, mortality is above 16% and ranges from 60 to 20%. And if none of the complexity features are there, mortality rate is down to 2. Which complications led to death? Organ failure, mainly liver, but also multi-organ. Refractory ascites, which was secondary to liver failure, bleeding, infection, and bile leaks. And as you can see, some of those could be prevented by many ways. We use the Clavian calculator to estimate costs of complications. And as you can see here, the overall cost of an operation is $12,000 within EU, US, and Switzerland. However, a complication that requires a reoperation doubles the cost, and a patient that is failed to be rescued quadruples. Hospital size did not have a huge effect on mortality. However, teaching hospitals had half the mortality of non-teaching hospitals, so that's on univariate analysis. Interestingly, private hospitals had a double mortality compared to public hospitals. Univariate analysis, this needs to be further looked at. And here I'm introducing the Human Development Index, which is a score that assesses life expectancy, education, and income indicators in a single statistic in order to be able to group countries into low, medium, high, or very high Human Development Index. And as you can see here, which is the main findings of Liver Group, is that. First of all, let me describe shortly the graph. The light green is a medium HDI country, the green is a high HDI country, and the dark green is for very high HDI countries. So, complexity, as you can see on the second set of columns, increased with Human Development Index. In fact, it doubled from 3 to 6. Morbidity was higher, major morbidity in medium HDI countries. Mortality was 13% in medium HDI countries, 7% in high, and 3% in very high. But the most important finding, which has been taken also from pancreatic surgery, is the failure to rescue rate, 33% in lower HDI countries. So 3 out of 10 of the patients that develop a major complication will die, compared to only 6%. So, to conclude, this is the first global surgery study specifically for specialized liver surgery. Overall mortality is, morbidity is 42%, major morbidity 33% at 90 days, and mortality of liver surgery is 3.8. It's not 0, as been described in several studies. Mortality in hilar cholangiocarcinoma is 19%, and that's something we need to look at. Failure to rescue is a modifiable factor of mortality, especially in lower HDI countries. And they say a good study brings, answers one question but creates new questions. The aim is now for members for the Liver Group that could work together to develop quality improvement collaboratives worldwide and see if we can reduce this failure to rescue rate. I'd like to thank everyone who participated in this study. Thank you.
Perhaps the most inclusive thank you slide I've ever seen. No, that was excellently presented. Congratulations on this. Just a quick question as we try to stay on time. Are the institutions that contribute the data to your data set, are they informed of of their outcomes as it compares with their colleagues around the world? It'd be very interesting. In the United States, we have a NISQIP database that shows us how we're doing compared to people. It doesn't tell us who they are. It just says, amongst your colleagues, your mortality is an outlier or it's not an outlier. These institutions that are taking the time to contribute this data, are they getting some feedback from you?
That's a great question. In fact, we did not do that systematically to all institutions. The beauty about our platform is they can download their own data in Excel format. They can look at their own data. But it's something we will certainly do after you mentioned, report on the major morbidity, mortality rates for their own data compared with the overall data. We did that for some institutions, especially from Holland, that they requested. Some others wanted to just look at how they did compared to other centers. But it's something we will certainly do. It's a very good idea. Plus, the data are going to be shared with all members, but of course anonymized, so people will be able to further analyze.
I have another small question. It's very interesting, the failure to rescue. Which is the complication that leads to death, which is modifiable, or where some work with the hospitals that have this?
Exactly. That's a very good question. So one prevention of a complication is not to operate on a specific patient if you think they're going to die. So that's one. But there are organ failures, for example, acute kidney injury, is something, also in liver transplant, that can be prevented by many means. And AKI is becoming now more and more of a hot topic, for example. So organ failure there of 26% was not liver failure only. It was kidney failure. And kidney failure can be prevented or ameliorated. Yes, exactly. And that's how you can see how ascites affected organ failure. Now, bleeding, no patient should die in a hospital from bleeding. That's an old rule. Of course, it can happen. But if you have the right setting and a patient bleeds, especially after liver surgery, you have to have the infrastructure and the support to be able to stop the bleeding, whatever it takes. Infection, better use of antibiotics. In fact, at the Royal Free Hospital, our infection rate was 42% instead of 9%. So we had to do something about it. So we already started including patients randomized trials to ensure that we can decrease infection rates. And by leak, I guess it resembles technique and seniority. So majority can be prevented.
Better.
Yeah, or improved.
Thanks again.
Thank you very much.
Thank you.
All right, our next talk is entitled Implementation and Outcomes of Robotic Liver Surgery in the Netherlands, a nationwide retrospective cohort by our friend, Dr. Jorgit from the Netherlands. Thanks for being back again.
Yes, thank you very much again.
Presentations are
Yeah, my presentations are
hidden.
a problem, I think. No, it's not this one.
No.
If you had another presentation, we'd rename the session after you, okay? So you're kind of taking over this session, it looks like.
Yeah, it should be the last one, I think. So.
There we go.
Yes, so thank you very much. So the next study I would like to present to you is our study, the implementation and outcome of robotic liver surgery in the Netherlands, a nationwide analysis. Again, nothing to disclose. Some background information, the use of minimally invasive liver surgery increased gradually over the last years, not only on a nationwide level, as you can see on the left figure, but also in several European high-volume centers, as you can see in the right figure. According to the most recent Southampton consensus guidelines, laparoscopy is now considered the standard of care for minor liver sections. And for major liver sections, laparoscopic liver surgery is considered feasible and safe, but should be performed in selected cases. So the most recent evolution in the field of minimally invasive liver surgery is robotic liver surgery. And it is believed that robotic liver surgery has some advantages. It is a platform for image-guided surgery, In comparison with laparoscopy, it has more articulation of instruments, the possibility of articulation of instruments with an optimal reach of posterior superior segments, and also better ergonomics for the surgeon. Several expert centers show the potential advantages of robotic liver surgery as compared to the open approach, including a shorter hospital stay and less severe complications. However, the widespread diffusion of robotics is still limited. And also, in line with this, studies in multi-center setting are scarce, and studies on national scale are even lacking. Since 2014, 9 Dutch centers of the 27 liver surgical centers in the Netherlands implement the robotic liver surgery program. And the aim of this study was to evaluate the nationwide implementation and outcomes of robotic liver surgery in the Netherlands, and additionally assess the learning curve during the first phase of implementation of robotic liver surgery. To do this, we performed a retrospective cohort study, including data from the 9 Dutch liver surgical centers with a robotic liver surgery program, including data from adult patients who underwent a robotic liver resection for all indications between January 2014 and March 2021. Outcomes we focused on in this study were intra and postoperative short-term outcomes stratified for the difficulty of resection. Yes, okay. And we also did a learning curve assessment using a QSIM analysis for blood loss. Between 2014 and 2021, more than 9,400 liver resections were performed in the 27 centers in the Netherlands, including more than 2,300 laparoscopic liver resections and 400 robotic liver resections, being 4.2% of the total. The first robotic liver resection in the Netherlands was performed in 2014, and from 2014 till 2020, the overall implementation rate in the Netherlands in all 27 centers calculated increased from 0.2% from 2014 to 11.9% in 2020. So we also looked at the implementation rate within the minimally invasive group, so all laparoscopic and robotic liver resections. And what we saw was that the implementation rate increased from 2% in 2014 to 28% in 2020. So this table shows the baseline variables of the 400 robotic liver sections in the Netherlands. Important to note is that almost 50% of the patients had a previous history of abdominal surgery, and more than 50% of the patients had a minor resection, and 13% of the patients had an anatomically major resection. So the overall outcomes were as follow. Median blood loss was 150 milliliters with a conversion rate of 6.3%. The severe complication rate was 7%. A length of hospital stay of 4 days with a radical resection status achieved in 83% of the patients, and a 30-day in-hospital mortality of 0.8%. This table shows the outcome stratified for the difficulty of resection for minor and technically major and anatomically major resections. Some interesting findings are a conversion rate varying from 3.9% to 9.6% in the anatomically major group. The severe complications varying from 5.4% in the minor resections to 12.5% in the anatomically major resections. And at last, the 30-day mortality 0% in the minor group and 3.9% in the anatomically major group. So we also did an analysis to evaluate the trends over time in outcomes. We compared the first and the second 200 robotic liver resections and stratified the outcomes for the difficulty of resection. And we found no difference in blood loss and conversion rate in the 3 difficulty groups between the first and the second 200 robotic liver sections. We found a hospital stay. We found that the hospital stay was significantly shorter in all 3 difficulty groups between the first and the second 200 robotic liver sections. The last interesting finding was that the overall morbidity after technically major robotic liver section was lower in the last 200, in the second 200 robotic liver resections as compared to the first 200 robotic liver resections. So at last, we did also a learning curve assessment for minor robotic liver resections. We couldn't find any learning curve for major robotic liver resections, including anatomically and the technically major resections. We found a learning curve of at least 33 major procedures before a proficiency was achieved. So in conclusion, the implementation of robotic liver surgery in the Netherlands was safe and feasible, with currently more than 1/10 of all liver surgery and more than 1/4 of all minimally invasive liver resections performed using the robotic platform. Outcomes of robotic liver surgery seems to be favorable, especially for minor liver sections. And that means that we have a good basis for extension of resection criteria in the Netherlands towards more major resections and also bilioenteric anastomosis reconstructions. However, we are not done yet. We need future studies to determine the added value of robotics as compared to the laparoscopic approach. Thank you very much for your attention.
Very nice presentation. Questions?
Quick question again from Norway. Should minor liver resections ever be done with a robot?
How do you mean that?
I mean, we all know that that's a laparoscopic procedure. You said it's the gold standard, and yet you have one of your final messages is that there seems to be favorable outcomes for minor resections with robot, and it kind of seems a bit strange because you don't actually need a robot to do them.
So I think that's the next thing we have to investigate in this field. So with this study, we found that the outcomes are favorable, only focusing on the robotic outcomes. And you're right, the next step would be to compare these outcomes with the laparoscopic approach to see if we should change our standard of care and say we should perform it by a robotic approach or laparoscopically. But you're right, it is now the standard of care. So I think it is an alternative for laparoscopy at the moment. But still, laparoscopy is a standard of care, yes. Yeah.
And I'm really happy that you're doing this this study because, like in Norway, we really didn't monitor the introduction of robot surgery at all. And it's extremely important to figure out where the true benefit of the robot is and where we can defend the added cost and where we can't defend the added cost. So I think the next steps of your work is really important. So
Exactly.
thank you.
Yes.
What did you expect when you started this study? I mean, here you have a lot of centers who have the robot, and in 7 years, the implementation in numbers has not been so straightforward. So, I mean, I think it's not the demonstration, but it gives the impression that the robot is not considered so useful by surgeons. Don't you have this impression?
Yeah, so I think what this study especially shows is that we are still in the beginning of the implementation of robotic liver surgery. And this study is the first study doing it on nationwide level. So this is the first time we can see how the robot was implemented in a nation, except all the multi-center studies done till now. And I think that's the power of the strength of this study, that we can see how this implementation was. And indeed, the implementation was not very, very high. It was 12%. But relatively comparing it with the implementation of laparoscopic liver surgery in the Netherlands, which increased from 6% in 2011 to 23% in 2016. That's still a higher, relatively higher increase than the laparoscopic approach. So it means something, I think. But we still have to investigate it and see what it will bring in the future.
Adnan.
Good morning. Nice to see you in person, Burke. Great presentation. I'm going to be much nicer than Asmund, but my question is you know, the laparoscopic platform, we saw that there was a lot of changes in learning curve and even complications as it became more stable. And now it's relatively stable, not a lot of changes in the last 5 years. robotic platform is changing drastically in the sense of different robots, but even in the same robot, there's a lot of new instruments and longer CUSAs and things like that. As you do this, you know, a lot of your data is going to change because what you're going to be able to do, robotic surgery in 5 years is not going to be the same as today. How are you going to address that, especially with implementation?
I think that's an important comment. And that's something we have to find out, I think, in a time. This is what we have in terms of data now. But we have a lot of data, so we should be able to stratify our results to see how different techniques apply and how different techniques give the results. So I think it's important to focus on in the future. But for now, yeah, at this moment, this is what we have in terms of data. But I think you're right. So it will still make a change, but this is the first step to see how the implementation was and how we did it with what we have now, with the Da Vinci and the types of Da Vincis we have. And still, there are still new developments. So probably in the future, we need to see again how this will be in terms of outcomes.
Yeah, I would push you too, just to look at some of the higher volume contributors to your data set, because with so many centers and so many individual teams and then surgeons within those teams, to try to establish the learning curve or the number of cases when it's really a collaboration of a lot of people, the learning curve is really best established by those most heavily invested in the data, like those that are contributing the majority of the cases. Perhaps to look at them individually, you might begin to tease out some sort of learning curve, but I doubt with so many centers and just a few here and a few there over so many years, your learning curve is going to be easily attained as a number from this data set currently. But just push you to keep doing this, because I do think it's incredibly important. We all struggle with what role does the robot really play. Thank you for a great presentation.
You're welcome.
Thank you
very much.
Okay, we have now the next presentation by Oriana Chacho, Preoperative Immunonutrition in Liver Resection for Cancer, Results of the PROPILS Trial and Multicenter Randomized Controlled Phase 4 Trial. Thank you.
Thank you, dear colleagues. I will present to you the results of the PROPILS trial about the preoperative oral immunonutrition in liver resection for cancer. I have nothing to disclose. Immunonutrition is the use of nutrients to improve the nutritional status of the patients and to modulate the immune and inflammatory response to stress. Arginine, glutamine, omega-3 fatty acid, and RNA are the key elements of immunonutrition. The concept of immunonutrition in surgery arises from the observation that chronic disease-related malnutrition is linked to the effect of an inflammatory state on metabolism, and from the observation that surgery is an acute inflammatory stress which can worsen immune dysfunction and also malnutrition. In gastrointestinal surgery and above all in colorectal surgery, immunonutrition has been proven to significantly reduce postoperative morbidity, postoperative infectious complication, and the length of hospital stay, regardless of the nutritional status of the patients. And so, in different countries worldwide, the use of immunonutrition is now recommended in all patients undergoing major abdominal surgery for 7 days before surgery. The immunonutrition in liver surgery is poorly studied, and actually only 2 studies analyzed and found the benefit of a parenteral immunonutrition in patients with HCC and cirrhosis. And only 1 study analyzed a preoperative oral immunonutrition, but this trial failed to show any benefit because of lack of power. So to date, the effect of a preoperative oral immunonutrition in non-cirrhotic patients undergoing liver resection for cancer is unknown, and the PROPILS trial was conceived to answer this question. PROPILS trial is a French multi-center double-blind RCT with 2 parallel treatment groups receiving either immunonutrition or an isocaloric control supplement for 7 days before liver resection for cancer. Inclusion criteria were planned elective liver resection for cancer, including at least 1 segment resected or 3 wedge resections. Exclusion criteria were benign lesion, cirrhosis, associated biliary tract surgery, and associated gastrointestinal surgery. The primary endpoint of the trials was the overall morbidity rate during the first 30 postoperative days, classified according to the Dindoclavian classification. Secondary endpoints were the rate of infectious and non-infectious complication, the length of antibiotic treatments and the length of hospital stay, compliance to treatment, and side effect of nutrition. It's a superiority trial based on the hypothesis of a significant reduction of the morbidity in the immunonutrition group, and according to sample size calculation, 400 patients were planned to be included. This is the workflow of the trials, and as you can see, to the standard preoperative and postoperative management of the patients, 4 evaluations of the nutritional status were added at inclusion, after nutrition, at hospital discharge, and 30 days after surgery. Between 2013 and 2018, 199 patients were included in the immunonutrition arm, and 200 patients were included to the control group. This is our intention to treat the population. Finally, 13 patients in both groups were not operated, and this is so our modified intention to treat the population. For these patients, it was not possible to assess the primary endpoint, postoperative morbidity. A per protocol analysis was also realized in 249 patients resected and who received more than 50% of nutrition. The 2 groups, immunonutrition and control group, were similar in terms of age, gender, in terms of past medical history, indication for liver surgery. Also, the number of patients receiving a preoperative chemotherapy and the number of patients with the chronic hepatopathy was similar in the 2 groups. The nutritional status at inclusion was similar in the 2 groups, as you can see in terms of BMI, weight loss, albumin and prealbumin serum level, and mini nutritional assessment short form score for patients more than 70 years old. Also, the patients meeting the malnutrition criteria, the rate was similar in the 2 groups. Adherence to treatment initiation was high, 90%, and similar in both groups, but only 15% and 18% in the immunonutrition and the control group received full treatment. The main cause for treatment discontinuation was, first of all, compliance, and then side effects. The more common side effects was diarrhea, and there was no severe side effect of preoperative nutrition. The evaluation of the nutritional status after nutrition didn't show any difference in the 2 groups, immunonutrition and control, as you can see in terms of BMI, weight gain, and the albumin and the prealbumin liver. Surgical characteristics are similar between the 2 groups. As you can see, no difference in terms of extension of resection, major or minor, type of liver resection, open or laparoscopic, operation time, vascular occlusion techniques, blood loss, and blood transfusion. The results. Overall morbidity rate was 61% and was similar in the 2 groups. Also, the rate of complication more than grade 1 of Dindoclavian classification was similar in the intended to treatment population. The per protocol analysis on patients operated and received more than 50% of the nutrition found the same results. As you can see, no impact of preoperative immunonutrition on overall morbidity. For the secondary endpoints, no impact of the immunonutrition on the rate of infectious complication, on the grade and the type of infectious complications, and no more on the length of antibiotic treatment for each complications. Concerning the non-infectious complication, no impact, so no difference between the 2 groups in terms of rate of non-infectious complications, severity, and type of non-infectious complication, and also no difference in terms of hospital stay, readmission, and mortality rate. So in conclusion, in non-cirrhotic patients undergoing a liver resection for cancer, preoperative oral immunonutrition failed in this trial to reduce mortality, infectious and non-infectious complication rate, and also length of hospital stay. So a preoperative oral immunonutrition cannot be recommended. Thank you for your attention.
Thank you for the nice presentation and for the tremendous effort of such a trial.
Thank you.
Are there any questions? I have one, two. The first one is, did you perform a subgroup analysis?
Yes, we analyzed, for example, according to the type of hepatectomy, major or minor hepatectomy, no difference. According to the nutritional status before hepatectomy in malnourished patients or normally nourished patients, no difference. And also we analyzed the subgroup analysis according to the compliance to treatment. For example, patients who received 100% full treatment versus patients with received no treatments or very small quantity of treatments, no difference, no more. So any difference.
And approach open versus laparoscopic?
No more.
Also,
We checked also no difference. And also by type of indication for surgery, colorectal metastasis, other metastasis, HCC, cholangiocarcinoma, any differences.
So thank you very much, Valerio Lucci from Brussels. Huge work, very important, I think. How do you explain that only 15% of patients completed their treatment? It's quite very low numbers. How do you explain this?
Yeah, the rate of patients receiving full treatments is very low, but as you can see, maybe I can, don't worry. The number of patients received more than 50% of treatment was high, 65 and 69% in both groups was similar. But as you say, the rate of patients received the full treatment was very low. The first reason was compliance. Between the answers we asked to the patients, the first answer was, I forgot to start treatment. I forgot to take one or two sachets of treatments. I forgot the day before surgery because of hospitalization. So this was the first reason, and a very small group of patients stopped the treatment for side effects. The first reason was compliance.
Last question, would you expect that the cirrhotic patient may benefit more from immunonutrition?
Maybe. We decided to not include the cirrhotic patients because there were in the literature just two studies, two RCT trials about HCC on cirrhosis using a parenteral nutrition. So this was the reason why we decided to do not include cirrhotic patients in this trial. But in the recent literature, a new recent study about HCC and cirrhosis show no benefits of immunonutrition also in cirrhotic patients. So the question is open. I think we have to analyze it. Thank you.
I'd like to welcome Dr. Rashidyan from Belgium to the podium to present next. The title of the talk will be Using Machine Learning to Predict Post-Hepatectomy Liver Failure and Postoperative Complications in an International Cohort of Major Hepatectomies. Welcome.
Thank you. Good morning. I'm Niki Rashidyan from Ghent University in Belgium. And I'm going to talk about using machine learning to predict post-hepatectomy liver failure and post-op complication following major hepatectomy as soon as I get my slides.
Yeah, we'll let you get your slides. That'll make it much easier.
Thank you. I have nothing to disclose. Post-hepatectomy liver failure is recognized to be the most common cause of mortality following liver resection. There are numerous criteria to define and classify post-hepatectomy liver failure, which among them, these three classifications are the most commonly used classification in literature, and they are basically based on laboratory data of total bilirubin and INR, and only ISGLS is also about the clinical criteria for defining postoperative liver failure. The objective of this project was to develop and validate models that can identify patients at the risk of adverse event following major hepatectomy. We have defined the adverse event as post-hepatectomy liver failure and postoperative complication. Post-hepatectomy liver failure was pointed as ISGLS B and C, and postoperative complications as having comprehensive complication index of more than 40. These numbers are based on the recent publication of our group that we found that in comparing the three different criteria, ISGLS is the more clinically relevant criteria, and ISGLS B and C are significantly predictor of 90-day mortality and CCI of more than 40. And grade A is not actually associated with adverse outcome. We have performed a retrospective multicentric study including 12 international referral HPB centers around the world, 4 centers in Europe, 1 in UK, 6 centers in Japan, and 1 in the United States. We included all the patients who underwent liver resection, major hepatectomy for all indication from 2010 to 2020. Major hepatectomy was defined as removing 3 segments or more, or 2 segments in case of liver cirrhosis. And all approaches to the liver surgery were included, anatomic and also non-anatomic resections. And we only excluded the patient with portal vein embolization and 2-stage hepatectomy. As a result, we collected the data of 2,192 patients. You can see in these tables that showing the clinical pathologic criteria of the patient. Of course, as we expect, most of the patients are colorectal liver metastasis or HCC, but we also have a large number of patients with cholangiocarcinoma, neuroendocrine tumor, as well as living donor hepatectomy. The median number of segments resected was 4 segments, which is representative of major hepatectomies. Half of the patients had a normal liver, and the other half were a kind of an impairment in liver due to chemotherapy, hepatitis, fibrosis. And almost 850 patients in the cohort had one type of liver cirrhosis, mostly grade child A. This actually is more of the machine learning graph showing the multidimensional data that we collected. I would like you to look at the number of the columns. This showing that we had all the data of the patient preoperatively, intraoperatively, postoperatively. Also detailed lab data of pre-op, post-op day 1, 3, 5, and the maximum level of the lab test and histopathology. The white dot in the graph are representative of missing data, and you can grossly appreciate that the quality of the data is quite good. So we had this amazing data to do or statistical modeling or machine learning modeling. What is the difference between the statistical modeling and machine learning modeling has been discussed at length in the literature. And I should say that there is no really clear-cut definition to distinguish the two. But there is something important about this to remember. The goal of machine learning and statistics are different. In statistical modeling, we are actually inferring the relationship between the variable to, and we are working based on the assumptions. So most of the most of the statistical modeling are using the strong assumption of linearity. In contrary, machine learning models are learning directly and automatically from the data. There is no assumption. Here the goal is to predict as precise as possible, and we are not having any assumption in advance. So I'm just showing you here, this is the multivariable analysis of the data that I just showed, and for most of you is really understandable. That's a coefficient table, and the things that we are seeing is the positive predictors that I have highlighted in red. And in the statistical modeling, we know that those who are positively related coefficient are the positive predictor in a linear way. Means that, for example, if the cholangiocarcinoma is a predictor, positive predictor of the post-hepatectomy liver failure, if the patient has that, linearly the result would be the same. And for the value that are like INR and bilirubin that is with the number, if the value goes up, at the same time the risk of the adverse outcome goes up. So this is how the statistical model performed. This is the ROC curve, and I would like you to look at the area under curve, which is for PHLF is 0.75, and for CCI is 0.72, and quiet is a good predictive value. These are the results of the machine learning. So we fitted 5 different models for the machine learning. They are for both ISGLS and CCI the same modeling. And we validated this as a 5-volt cross-validation in the training set and also boosting sampling in the holding out test. And for ISGLS, you can see that here balanced random forest was the best performing model that we got. And this is the same graph for the rock graph for the machine learning for ISGLS. And you can see that the AUC is 0.79. Just to remind you, the statistical modeling was performing slightly worse than this. And in the right side, you're seeing the learning curve of the machine. This graph, actually the green line in bottom, is suggesting that the most of the learning happened in the data point of 200, between 200 and 400, and afterward, the machine didn't perform any better with 1,000 more data that we have provided. So this may be suggesting that maybe 400 data was enough for this modeling. Now look at CCI. Again, for CCI was random forest the best performer. We did the same modeling here also. And here the area under curve is 0.78, again slightly better than the statistical modeling. But look at the learning curve. You see that from 1,200 to 300, you see a raise. This is suggesting that probably if we add 100 more data to this, could be that we go a bit better. Is it happening or not? That we have to investigate. This is also the feature importance. This is kind of correspondent to the multivariable analysis that we do in the statistics. We have some features that are more important in the model. But there is a big difference between feature importance in machine learning with the statistical. Here, we cannot say for individual person, if you have a higher INR, you are in the more risk of developing post-hepatectomy liver failure. The only thing that we can say from this feature importance is that if we can provide machine with a large number of INR, probably it performs better. That's the only conclusion that we can get from this feature importance. So to conclude, what we can say, what machine can do better than a statistical modeling is that we can unlock novel insights that are really are not understandable or realizable by the human eyes and human mathematic modeling. It's a highly flexible algorithms. You can actually include as much as variable. The ideal data set for the machine learning is a multi-dimensional data set, and it can handle a large number of potential predictors. And it's very important that machine learning is free from prior assumption. But it doesn't sound always cool to do machine learning because it has a lot of limitation. You can see we obviously need a lot of more data, but how much more data we need, we don't know. You have to collect the data, feed the machine, and see where you get the plateau. And it's very complex processing always. It's at a very high risk of overfitting because unfortunately or fortunately, I don't know if it's the value or disadvantage, that machine doesn't have the common sense. It's just see what we are feeding. So that's result a very high risk of the overfitting, and it's difficult to interpret. In other words, here we are trading the interpretability with the preciseness of the decision. So we cannot understand it really very well. So we have used the machine learning model, and we have developed a predictor for post-hepatectomy liver failure and CCI of more than 40. This predictive tool can work as a stratifying the patients preoperatively and adding the adjuvant pre-op treatment if needed. And then the next step of this would be that to validate this model on the prospective data. Thank you so much, and happy to answer the questions.
Very nice. We have time for a quick question.
Thank you very much, Stefan Grieg from Stockholm. I think it's a very interesting approach you're using there, because PHLF usually is a multifactorial problem. It's just one problem I have with this, just the presentation or the prediction of PHLF does not help very much the patient. And what we are looking for over a couple of years now is actually to predict PHLF as early as possible in order to can provide some intervention for the patient. What do you think is the future perspective of this time-wise in the postoperative setting? What can you add in this setting with this kind of technique in order to predict as early as possible in the postoperative period that the patient will develop serious PHLF and have a high risk of 90-day mortality?
Yes, thank you so much for this question. Actually, I didn't go very in detail of the clinical use of it. I should say all the modeling, statistical modeling and machine learning modeling was performed on the preoperative data. So we used the preoperative data to provide the prediction before the surgery. And the next step in this project is that we are gonna make a nomogram for both machine learning and the statistical model. You can provide the preoperative data of your patient, and it can tell you that if it's gonna be at high risk of PHLF or not. And if you get this in forehand before surgery, I believe that we still have other clinical tools to use for example, augmentation of the remnant liver and the other criteria that we can use preoperatively.
Thanks so much.
Thank you.
Thank you.
The next presentation is given by Natasha Ley. Increasing morbidity and mortality after hepatectomy for colorectal liver metastasis in frail patients is largely driven by worse outcomes after partial hepatectomy. It's not just a wedge.
Thanks. Good morning. Thank you for inviting me to talk today about the impact of frailty after hepatectomy for colorectal liver metastases.
Everybody's doing a good job staying on time. We're just falling down in between. It's our fault. There we go.
Perfect. Thank you. I have no disclosures. A third of colorectal cancer patients are diagnosed with liver metastases at some point in their disease. Although survival rates after hepatectomy are encouraging, this must be weighed against the significant morbidity of surgery. With more elderly and comorbid patients now being offered surgery, it is increasingly important to risk stratify these patients preoperatively. Frailty, a syndrome of both physical and functional decline, is independently associated with worse perioperative morbidity and mortality across multiple surgical specialties. The RAI, which is a score that incorporates 14 variables to measure frailty, is validated for use in NSQIP in multiple surgical procedures. It has also been shown to predict perioperative outcomes and reduce mortality when used as a preoperative frailty screening tool. However, it has not been validated in hepatectomies. Data on the impact of frailty on perioperative outcomes after hepatectomy is limited to very few studies in heterogeneous populations. They do, however, seem to suggest that frailty is predictive of morbidity after liver resection. A 2018 study by Van der Wint is the only study to evaluate RAI as a frailty index in HPB surgery. This was conducted in a small cohort of patients undergoing various HPV procedures. Despite these limitations, RAI was again found to be an independent predictor of multiple poor outcomes, including perioperative complications. And even 1 unit increase in RAI had significant impact. As such, we sought to use the NISQIP database to evaluate the utility of the RAI score as a measurement of frailty in predicting perioperative outcomes after hepatectomy for colorectal liver metastases. We hypothesized that frail patients would have worse outcomes than non-frail patients, and that frail patients may tolerate a minor hepatectomy better than a major hepatectomy. We retrospectively reviewed data from the NISQIP database, which collects data from 141 hospitals from 2014 to 2019. All patients who underwent elective hepatectomy for colorectal liver metastases were included. The population was divided into 3 cohorts, non-frail, frail, and very frail, in order to determine the effect of frailty on perioperative outcomes. Perioperative frailty was scored using the RAI score. The components of the score, as you see here: age, sex, malignancy, weight loss, poor appetite, congestive heart failure, shortness of breath at rest, renal failure, cognitive decline, residency, and functional status. Patients were then classified into frailty groups based on the RAI percentile rank of the entire cohort. Non-frail patients had RAI scores below the 75th percentile, frail patients from the 75th to 90th percentile, and very frail patients above the 90th percentile. Primary outcomes were to determine if 30-day perioperative complications and mortality were worse in frail than non-frail patients. We also sought to determine any predictors of complications and survival to aid in identifying at-risk patients who may benefit from an alternate management strategy when planning treatment for colorectal liver mets. So we evaluated 25,595 patients over a 5-year period, and after excluding emergent procedures and those performed for another diagnosis other than colorectal liver mets, there were 8,477 patients who underwent hepatectomy for colorectal liver mets. 70% were non-frail, 20% were frail, and 10% were very frail. Expectedly, there were some significant demographic differences between these 3 frailty groups, given that the RAI score is composed of several of these variables, as listed previously. Although there was a difference in the number of liver tumors present, there were no differences in preoperative chemotherapy or PVE between the 3 groups. The presence of background liver cirrhosis was also similar. Intraoperatively, frailer patients did not undergo less extensive surgery. They had similar surgical procedures and extent of hepatic resection and concurrent liver ablation. However, they were significantly more likely to have had a Pringle maneuver performed. In fact, frail patients were also significantly more likely to undergo concurrent colectomy. The most striking results are seen here. Frail patients had significantly higher rates of post-op complications across the board, including cardiac, pulmonary, renal, hematologic, and liver-specific. They had a significantly longer length of stay and were significantly more likely to either die within 30 days or be discharged to a facility. In fact, the more frail the patients were, the poorer the outcomes. On multivariate analysis, frailty was an independent predictor of overall complications and 30-day mortality. Very frail patients had almost twice the likelihood of having a complication and over 4 times the odds of dying. Other significant predictors included open surgery, major hepatectomies, and concurrent colectomy. Interestingly, concurrent liver ablation was predictive of fewer complications and likely serves as a marker of parenchymal-sparing surgery. When outcomes were stratified by the extent of hepatectomy, frail patients had significantly more complications than non-frail patients after partial hepatectomy. Complications were similarly high for major hepatectomy. The same was seen for mortality. Frail patients again had significantly higher mortality rates than non-frail patients after a partial hepatectomy, but again, no difference after major hepatectomy. On multivariate analysis of only patients undergoing a partial hepatectomy, similar results were seen to the prior analysis of all hepatectomies. Again, frailty was an independent predictor of both overall complications and mortality. Very frail patients had almost twice the likelihood of complication and over 6 times the odds of dying in the perioperative period after just a partial liver resection. In summary, in patients who underwent surgery for colorectal liver metastases, frail patients underwent similarly extensive hepatic resection to non-frail patients that had significantly higher complication and mortality rates even with just a partial hepatectomy. Given this convincing evidence that frail patients do worse after hepatectomy, regardless of the extent of resection, we recommend that preoperative frailty screening be implemented in all patients being considered for hepatectomy. Any patient identified as frail should be considered for a prehabilitation program to try and modify their risk profile, regardless of the extent of hepatectomy. When feasible, frail patients should be considered for minimally invasive and parenchymal sparing techniques. Thank you. I will take any questions.
Thank you for your excellent presentation. Did I understand well that frailty does not impact on outcomes after major hepatectomy?
They all do badly, basically, and that the degree of frailty didn't impact it, yes. Correct.
How can you explain this? How do you explain that frailty impacts on wedge and not on major hepatectomy?
I think that the outcomes after major hepatectomy, the complication rates were fairly high across the board, even for, non-frail patients. And I think that it's really being driven by the wedges, is that people say, oh, it's just a wedge, it's nothing. And that actually it shouldn't be underestimated. Then they have, just having a poor nutritional status, just having poor, functional status is the major impact. I think it's not that their complications were good after major hepatectomies, it's just that everybody's very high.
Okay, please.
Wonderful presentation and really amazing data. My question is, do you think we have a very good assessment of frailty right now?
I think no. We use the eyeball test, which I don't think is a good test. I think that, RAI has been validated across the board. It was published in, annals, and it's been used across the board for even hernia repairs, et cetera, et cetera. And I think this study demonstrates that we should be using it in hepatectomies. And I think that, just eyeballing a patient from the door and saying, oh, yeah, you look pretty good is not good enough. No. And there are lots of modifiable risk factors within this, such as, functional status, did they come from a nursing home, all that stuff. So I think that it should be put into the algorithm. People should be scored. It shouldn't be, it shouldn't be subjective, it should be objective.
100% agree with you that it's better than an eyeball test, but my question is it good enough for HPV patients? Is it specific enough? Because I feel like, similar to the question, is that I feel like that it shows us something, but there's something missing if the minor and major is all the same.
Yeah, I agree. I mean, I don't know, ultimately, if it's specific enough. On a side note, we have a prehab program at WashU that we've implemented fairly recently. It started off in pancreatectomy patients, and now we've rolled it out to everybody. And a separate set of our internal data showed that when patients, part of our prehab program is a Fitbit, and they, when they walk more than 5,000 steps a day, their complication rate significantly goes down. So, I don't know if this score in its entirety can assess it, but I think that's pretty compelling evidence. And so, we would like to prospectively analyze our, major liver resection sarcomas that are all getting these, on the prehab program to see if we can compare it retrospectively to a matched cohort and see if it really is making a difference.
Thank you for the presentation. You mentioned you seem to be dismissive of the eyeball test. But in various other scenarios, eyeball test has been shown to be effective. For example, end of the bed analysis of the patient has been shown to be as good as complicated scores. Perhaps we need to do a trial to compare the two before we dismiss the eyeball test, because an experienced clinician can make a diagnosis of that and it can predict. Did any of these programs have prehabilitation? Because we're doing this big time in the UK now, but did any of them already have rehabilitation, or they didn't?
So this is NISQIP data, so it's de-identified. We can't tell which hospitals it is. There is not that data available. However, given that the fact that this was up to 2017, 18, 19, my feeling is probably not, because I feel like it's come more into existence over the last sort of 2-3 years. But unfortunately, that data is not available to us.
Thank you.
Thank you for a nice presentation.
Thank you.
I'd like to welcome Dr. Saranari to the podium from Italy, who will be presenting our last oral presentation. Then Dr. Shaki is going to show a video as well. So thanks for sticking around. We got started a little late. This presentation will be entitled Evolution of Techniques and Surgical Outcomes of Associating Liver Partition and Portal Vein Ligation for Staged Hepatectomy in Italy, a comprehensive trend analysis over 9 years. Welcome.
Hi everyone, my name is Matteo Serenari and I'm working at Hepatobiliary and Transplant Unit in Bologna. Thank you for accepting our abstract. So I have nothing to disclose. Let's start with a brief introduction. So as you know, in 2007 it was performed the first ALP procedure at the University of Regensburg by Professor Schlitt. It was called at the beginning in situ splitting, and in 2011 the first largest series was published, and 1 year later the ALPS registry was founded, up to the present days when important trials were published on this topic. In the middle, and more precisely in 2015, the first international consensus meeting on ALPS was held in Hamburg, and on that occasion we also won the Best Poster Award and published in the following year the paper on the importance of primary indication and liver function between stages. But more importantly, some recommendations were made by a panel of experts. In particular, it was recommended to avoid any manipulation of the hepatic hilum, and also the depth of a partial transaction that can be performed in place of a total transaction was also defined. And it was recommended also to delay stage 2 in case of liver failure in the interstage. And also the use of functional tests was highly encouraged. And caution was recommended to use ALPS for hepatocellular carcinoma, intrahepatic cholangiocarcinoma, and perihilar cholangiocarcinoma. And it was also recommended to consider longer intervals between stage 1 and 2, especially in case of liver failure between stages and with aged patients. So our aim was to analyze the trend and the outcomes of ALPS over a 9-year period within the series of a prospective national registry, and also the effect on the consensus on the practice of ALPS in Italy was analyzed. So patients enrolled into the so-called ALPS Italian registry were analyzed and divided into 2 eras, before and after 2016, and to calculate annual percentage change and P-trend joint point regression analysis was used. On December 2021, 268 ALPS were included, with 16 centers providing data on an intention to treat basis. As you can see, number of centers that perform ALPS did not increase over the years, whereas number of ALPS increased from 22 in 2012 to 28 in 2020. But when we divided the number of ALPS by the total number of hepatic resection performed by the centers, this number did not significantly change over the years, ranging from a minimum of 0.8 to a maximum of 1.3%. When we compare the 2 eras, only ASA score was significantly different between the 2 groups, with less severe patients operated in the second era. And even though indications were not significantly different between the 2 groups, we found that the colorectal liver metastasis and perihilar cholangiocarcinoma decreased over time, whereas intrahepatic cholangiocarcinoma and hepatocellular carcinoma increased over the years. In stage 1, we found that minimal invasive approach, partial parenchymal transaction, and portal vein embolization were more frequently performed in the second era, and similarly discharge before stage 2 was significantly more adopted in the second era, as well as interstage functional assessment, which was performed more frequently in the second era after 2016. In stage 2, in the second era, stage 2 was performed in median 4 days later than the first era. And also in this case, a minimal invasive approach was significantly performed more frequently in the second era. And among the various outcomes, only major morbidity was significantly different between the two era, with less severe complication after 2016. Hospital stay was also significantly shorter after 2016. So when we look to this figure, we found we see that there was an increased trend of minimal invasive approach techniques over the years. With also a few robotic cases in the last 2 years. And in stage 2, full minimal invasive approach was attempted in 28 patients with completed ALPS, full laparoscopic, full minimal invasive ALPS in 20 out of 28 patients. And when we go back again to this table, we found that 90-day mortality was not significantly different between the two groups. However, it decreased from 15% to 10%, but no significant trend was found over the years. Similarly, liver failure between the two groups was not significantly different, but in this case, we found a trend close to the significance level with an APC of -6.3. And we also tried to stratify by indication, and all outcomes improved across the 2 eras, except for liver failure and 90-day mortality in colorectal liver metastasis group, and for every outcome in perihilar cholangiocarcinoma. So in conclusion, use of ALPS remained stable over the years with improved outcomes after 2016, especially for what concerns major morbidity. Perihilar cholangiocarcinoma seemed to benefit less in this sense. Liver failure should not be underestimated also in colorectal liver metastases, which are considered classically not a high-risk group for liver failure. And for this reason, interstage hepatobiliary scintigraphy is recommended. And there was an increasingly use of minimal invasive approach, which maybe led to improved outcomes. Thank you for your attention, and thank you, of course, to the whole Italian team.
Thank you for a very nice presentation. Maybe they can grab you after the session for a question as we try to catch up just a bit. So thanks again.
Okay.
I'd like to welcome Daniel Cherki to show a video. I can remember 20 years ago watching videos from Dr. Cherki as he did live donor laparoscopic liver resections 20 years ago almost. And so it's a privilege to have him share a video with us this morning as we conclude the session.
Well, thank you, Clark. Thank you for the invitation, and thank you for staying. Here it is. So we're still doing living donors. In these days, it was left lateral for pediatrics. So no disclosure. So I'm going to show you a living donor right hepatectomy using laparoscopic surgery and enhancement with ICG. So it was the donor was a 47-year-old woman. The recipient was a 55-year-old husband with HCC and HCV cirrhosis. Surgery was a few months ago. So we used for a 4K widescreen 30-degree laparoscope. And this is the patient position and the port placement. The ports are like this. The camera is facing the transection line. The working ports are on both sides of it. And you have also some exposure ports. So this is the video. We start by dividing the falciform ligament and then exposing the we start the right liver mobilization. The liver mobilization is standardized, coming from above as far as you can on the right. And you expose the confluence of the 3 hepatic veins. Then we're going to continue the mobilization. Here's just a adhesion, and we're going to lift the right lobe to mobilize the right lobe this way. And then we will go to the side. And the patient, we turn the patient to the left side so we can use gravity to mobilize the right lobe, and we join the lower and upper dissection this way. You have to be careful here because the IVC and hepatic veins are very close. Then we skeletonize the IVC. Here is a inferior right hepatic vein, which is less than 5 millimeters, so we elected to divide it, and it's not going to be reimplanted. Please note that the IVC is really pulsating, meaning that the patient has low CVP, and the anesthesiologists are doing a great job, and it's paramount that we have excellent anesthesiology for that. This is the IVC ligament, which is also stapled, and this gives access to the root of the right hepatic vein. So here is the right hepatic vein. It's going to be encircled, and we're going to place a tape that's going to be eventually used for the hanging maneuver. So encircling the right hepatic vein, putting a tape, and this will be used at the end of the transection, as you will see. Now we move to the hilar dissection, and here is the cholecystectomy. However, we just do the cystic duct and cystic artery, and we keep the gallbladder as a handle for exposure. So the gallbladder is pushed above. So we just part, and then we grab the cystic duct to expose the right hepatic artery. Here is the right hepatic artery. We recut the cystic artery flush with the hepatic artery, which allows to control that artery. Put a tape around it. And then we move to the portal vein, and there was a rather short right portal vein, not a rather short one, so we first control the posterior and anterior branches. This is and you can see the anterior branch. And ICG is coming. And here is the anterior one. And so this allows us to really see the portal vein trunk and the left portal vein clearly, so we are sure that what we get is only the right portal vein. This is something that's very important. Now we clamp the right hepatic artery and the right portal vein, and we see an ischemic demarcation. We inject now 5 milliliters of ICG, 5 milligrams of ICG, and we can see here that the ICG not only shows you the surface of the demarcation, but also inside. And then we move to the transection. The transection is a combination of energy device for the periphery of the liver, and then we cut segment 1, which eventually will be very important for bile duct control. And then we use a combination. Now it's CUSA. So the CUSA is used with monopolar cautery. And we use intermittent Pringle maneuver in donors, which is something that can be discussed only in case of necessity, but it's always there ready. And this allows to have a totally bloodless transection line, but also to make it much quicker. It's intermittent clamping, only for 15 minutes, 5 minutes, and we use it 2 or 3 sessions during the case. And what's going on? Oh, no, you can't do that. Okay, thank you. Then we pass the tape. Well, we lost some of the video, but that's okay. So we pass the tape above the bile duct, and then we divide the final part of the transection. Of course, the IVC has been dissected before, so there's no risk to the IVC, and this is the posterior capsule of the liver. And now we're going to get only the bile duct and the hilar plate. And then we use ICG again, and here you can see the common bile duct, the right hepatic duct, and the left hepatic duct. And this is very important. This is a game changer for the area of division of the right bile duct, which was before more difficult, and we need to use intraoperative cholangiogram, which we don't anymore. And then we cut the bile duct, and then we clip the remnant hilar plate. There may be a small bile duct here, and eventually it will be ligated. It's a very small 2 millimeter bile duct, or 1 millimeter bile duct. And then we're ready for harvesting the graft. So we pre-place it in the bag, and this is the right hepatic artery division. 2 clips, one lock clipped and one metal clip. Then we cut the portal vein using a unilateral stapler, the endo-TA stapler, which, by the way, is not made anymore by Medtronic. So because if you use a double stapler, then you need to remove the staple line for reimplantation. And this is the right hepatic vein. I think here we used the new, very thin stapler that allows not to take too much. And then we recut the staple line. But we can also use a unilateral stapler. So this is done. Then the graft is put in the bag, extracted. And this is the way we close the bile duct. And we use ICG again to check that the remnant bile duct is okay. And this is a final view. And then I have a couple more slides and just to show you the outcome. Oh yeah, reattach the right lobe is very important to avoid torsion Budd-Chiari syndrome. Can you move to the next slide, please? Oh, I'm doing it, sorry. So this is we do a CT scan before discharging the donor all the time, and it was uneventful, and this is the recipient. So in conclusion, ICG fluorescence enhances pure laparoscopic donor right hepatectomy. We inject the ICG after clamping of the right portal pedicle. It shows a clear demarcation of the parenchymal demarcation. It shows biliary confluence for an easier and safer division of the right bile duct. It shows the remnant bile duct continuity at the end of the procedure. And it has made intraoperative cholangiogram unnecessary in most cases nowadays. Thank you very much for your attention. I guess we have to go to the...
Yeah, I think we have to dismiss, but thank you so much, Daniel. That's beautiful work. I want to thank you, everyone for staying later, and appreciate all the input and questions and comments. Thank you.
Thank you again.
All right, we ran a little late, but that's okay. It's good to see you. Oh, it was very nice. Very nice to meet you too. It's a beautiful video, isn't it? Oh my goodness.
In Westberg, we would shoot 3 cholangiograms. I was case with that 3 cholangiograms. You know, beginning, before you cut the bile duct, after the case. That's beautiful the way he said it.
Ging het goed? We hebben, onder leiding van Babs hebben wij denk ik 3 keer gezocht naar zak. Ja, wij zagen daar. Ja, maar ging het goed?